This is Dr. Robert Beasley. I would like to thank the Scientific Advisory Board of Icarus for the invitation to speak today. Today, I'm going to speak on a novel below-the-knee stent, the microstent, and I'm going to speak on also intravascular ultrasound and what I believe this technology brings to true imaging and treatment of the below the femoral popliteal vessels and especially the tibial vessels. These are my disclosures. So, why do we worry about below the knee artery stenting? Well, because right now in the United States, at least, the only technology that has been approved for below the knee intervention by the FDA is plain old balloon angioplasty. And it was shown by Dr. Baumann in the Journal of Endovascular Therapy in 2014 that in a large series of patients he looked at, that elastic recoil was observed in 97% of the patients that he looked at that had tibial balloon angioplasty with a luminal compromise of 30% at 15 minutes post dilatation. So therefore, he showed that early recoil was frequently observed and could contribute not only to restenosis, but also to occlusion. Dr. Marianne Brodmann and Andrew Holden showed also in the TOBA BTK study arterial arm that localized PTA dissection was common in tibial angioplasty and that it was also associated with significant restenosis and occlusion. So at this point, really the only treatment for failed tibial angioplasty in the United States is balloon expandable coronary drug-eluting stents. These have worked pretty well, and there have been several retrospective studies that shown that they worked very well when compared to balloon angioplasty and plain old balloon expandable stents, which without drug. However, these stents do not perform great in the lower half of the leg, and these stents are very susceptible to compression, and compression then can then cause restenosis and occlusion. So I'm very happy to talk about and pleased to talk about a new stent, which is FDA we're trying to have FDA approval in the States, and it's also CE mark approved in Europe. It's the microstent. It is a stent for below the knee arteries. And it's very well seen with intravascular ultrasound, which will show some of those attributes in a few minutes. It is a tightly woven nitinol stent, which really fits very, very nicely to the tibial arteries. It has a 3 French delivery system through a microguide catheter. It's available in a 40 centimeter retrograde pedal and a 100 centimeter antegrade approach. It has a fantastic property that allows it to be seen not only with angiography, but external duplex ultrasound and intravascular ultrasound. It does have a platinum core design. And especially with intravascular ultrasound, it provides a roadmap for accurate sizing of the stent to the vessel, as well as lesion assessment and stent wall apposition. So delving a little bit more into why we think intravascular ultrasound is so important in the treatment of this disease, and especially with the microstent, it's been shown that angiography severely underestimates the level of disease in the above the knee as well below the knee arteries. You can take a look here on the bottom panel on number A, where you can see it looks like just a very mild stenosis, if any. And then you can see with intravascular ultrasound how there's probably a 70 to 80% stenosis. Intravascular ultrasound also improves outcomes post-deployment of the stent. As you can see on this cartoon to the right, there you can see incomplete stent apposition very nicely with intravascular ultrasound, as well as stent under expansion and edge dissection. As far as the case for using intravascular ultrasound with below the knee stenting, it's been established that angiography alone provides luminal characteristics of the peripheral arteries, yet yields very little information on the true extent of the underlying plaque burden, knowledge of the morphology, or true size of the vessel. In fact, recent studies have shown better outcomes in peripheral interventions with IVUS use along with angiography. A meta-analysis of 13 studies composed of more than 2,250 patients demonstrated a significant difference in amputation rates and frequency of reinterventions, favoring the use of intravascular ultrasound. Other studies, including over 90,000 patients, demonstrated significantly lower post-procedural complications, lower amputation rates, and a non-significant increase in hospitalization costs with intravascular ultrasound use. As far as the microstent goes and the clinical trial status at this time, the U.S. feasibility study is complete. The study looked at the initial experience with microstent. It showed a 91% primary patency and a 100% freedom from major adverse limb events and perioperative death at 12 months. As mentioned before, the HEAL registry, which is ongoing in Europe, is enrolling. It began enrolling in October of 2019. Marco Manzi is the PI of this study. Some initial 6-month results have shown very encouraging primary patency results of almost 90% at 6 months with an excellent safety index. The STAND study in the United States is now ongoing. It is a prospective multi-center randomized controlled trial. And again, it started enrolling in March of 2020. Here are a couple of cases from the feasibility study that we have. The baseline angiogram showed a high-grade stenosis of the mid-anterior tibial artery. Angioplasty was performed. Angioplasty showed a significant dissection. The stent was then deployed. You can see in the middle frame, the stent is very easily visualized. And then following stent deployment, imaging was performed showing an excellent result. This patient had a widely patent stent at 6 months. And as you can see here, it's very highly visible on external duplex ultrasound. You can see on the lower panel how the normal vessel is native vessel to the left, and then to the right, you can see the stent being very, very visible. Here's another patient that we did in the feasibility study. This patient was a Rutherford 5 with a toe wound. Patient had a high-grade stenosis, a subtotal occlusion of the anterior tibial artery and a high-grade stenosis of the perineal artery. The patient was accessed from below in the dorsalis pedis, lower anterior tibial location, and we came up from below using the 40-centimeter retrograde pedal platform. Also, we came in from above with a balloon and ballooned the perineal artery. And you can see here, as far as deployment, we were able to stack the stent in a very nice fashion up against the balloon and then deploy the stent in a pin and pull fashion. We prepared the vessel prior to this with balloon angioplasty so that the stent could be very easily deployed. Following deployment of the stent, post-dilatation was performed. And in each case, I must say, we used intravascular ultrasound for the procedure before this, as well as for this one, in order to adequately determine the diameter of the vessel for stent deployment, as well as to make sure that the stent vessel wall apposition was appropriate. And you can see over here the results from the stent placement. And over on the far right-hand side, excellent visualization of the stent post-deployment. So in conclusion, as CLI fighters, I believe we need a combination of tools for optimal outcomes, not only including new stents, but also the use of intravascular ultrasound for the placement of these stents, as well as other technologies that are being developed. We need to have stents that are proven in longer lesions, not just lesions in the upper part of the leg, but lesions that can be taken care of and treated in the mid to lower third of the leg. We also need to have stents that are very easily visualized under not only angiography, but external ultrasound, as well as intravascular ultrasound, which I hope I've shown in this talk that it is something that we all need to be using. I think in every single occasion we have not only above but below the knee interventions. And we need a reliable stent platform which provides adequate radial strength to oppose recoil, will not be crushed, will not be fractured, and will not produce an occlusion, And we need to have a stent that has minimal chronic outward force to achieve optimal vessel wall apposition without inducing a significant neo-intimal hyperplasia for in-stent restenosis. So thank you very much.